Assalamu alaikum colleagues. Welcome to our lecture series of critical care and resuscitation. In today's video, I will discuss the ultimate guide to the golden hour, specifically for preterm infants having gestational age less than 28 weeks. In this video, I will discuss basically from counseling to stabilization. But before this, I will just give a brief intro about this lecture. So, if you want to skip this part, you can skip and directly go to the main lecture part, that is the second part. I have divided this lecture into three phases. So, starting with a scenario, imagine you are called to a delivery room. A 26-week gestation infant, estimated at 800 grams, is imminent. The mother is hypertensive, the baby is born limp and pale, and the clock starts now. What you do in the next 60 minutes, the golden hour, will decide not just the baby's survival, but their risk of intraventricular hemorrhage, bronchopulmonary dysplasia, and long term neurodevelopmental impairment. In the past, our goal was simply survival. Today, our goal is intact survival. To do this, we must combine the wisdom of classic textbooks like Gomella and Nelson with the precise evidence based updates from the Neonatal Guidelines 2025 till 2028 and the new NRP 9th edition, which is just released. So, let's walk through the timeline before delivery, in the delivery room, and stabilization. So, let's begin with the first phase, that is before delivery, the pre-game. So here is our phase 1, that is before delivery. Success is determined before the baby is even born. Gomella's neonatology emphasizes that the golden hour actually begins with the antenatal consultation. You must meet the family, discuss survival statistics, but focus on the care plan. Nelson reminds us to discuss the risk of neurodevelopmental impairment, not just mortality. But Gomella highlights the gray zone, that is 20 to 24 weeks preterm. Verify parental wishes for active versus palliative care. So, before delivery, we have to counsel the mother. So, first one here is counseling. Counseling related to the affects, the developmental issues, and other issues which is eminent in this case. The second part is the team briefing. Assign roles clearly. There should be a airway leader which manages the head. One is with circulation access which manages the UVC. Third one, the recorder or the timer, often forgotten but critical for documentation. So, after counseling, the team briefing is important. So, the second part is team briefing. After the team is briefed about who is going to manage the role of airway, who is going to play the role of circulation or managing the UVC line, and who is going to record all the events. The NRP 9th edition emphasizes on behavioral skills and the pre-resuscitation checklist. You must specifically discuss risk factors, identify the team leader, and delegate roles before the birth. The briefing is no longer optional, it is a standard of care. The third and the most important part of the before delivery phase is environment and the equipment check. This is where the 2025 guidelines are strict. First is temperature. The delivery room temperature must be in between 23 degrees centigrade to 25 degrees centigrade. Gomella calls this the cold stress killer. Hypothermia on admission is an independent risk factor for mortality. So, in environment and equipment, the third one in this phase is environment and equipment. And the most important here is number one, the temperature of the delivery room. So, the delivery room temperature should be in between 23 degrees Celsius to 25 degrees Celsius. Second one is equipment check. So, equipment, we must preheat the radiant warmer to maximum output, and we must have a food grade polythene bag. Have this open and ready. And the third one is the blender. Set your oxygen blender. We will discuss the specific fractionated oxygen shortly in the next phase. So, number one is temperature, number two is equipment check, and in equipment check, we must have a preheat warmer and polythene bag, a food grade polythene bag, and the third one is oxygen blender. So, we must have a counseling session with the parent to know their well. After this, we must have a team briefing so that everyone should be clear about their roles. And the third and the most important in before delivery phase is environment and equipment. After all this, we have the delivery room. The baby is being delivered, and the clock starts with different steps. Here is your workflow. In step 1, we have the cord management. Second one is ad delivery, and in this we have the first minute of this, that is the cord management. Before the 2025 guideline, we have different guideline for this cord management, but the guideline has changed in 2025 for vigorous preterm infants. Delayed cord clamping for at least 60 seconds is emphasized. So, first one in this is delayed cord clamping if the infant is vigorous, and this is for first 60 seconds. What the physiology behind this? This is because this provides a placental transfusion of up to 80 ml of blood, boosting blood pressure and reducing the risk of IVH and neck. So, this delayed cord clamping is basically giving the preterm infant an extra amount of 80 ml of blood. which prevents the infant from intraventricular hemorrhage and necrotizing enterocolitis, that is IVH and NEC, which are the two important mortality factor for preterm infants. There is one more important point in 2025, that is cord milking. You might read in older textbook about cord milking as an alternative. However, recent evidence updates in 2025 warns against cord milking in infants less than 28 weeks because of higher risk of intraventricular hemorrhage. Stick to delayed clamping unless the baby or mother is hemodynamically unstable. So, cord milking must be avoided in preterms less than 28 weeks because it can cause intraventricular hemorrhage. So, there would be more risk of IVH if we cord the milk. So, new guidelines strictly warns us avoid cord milking in preterm infants less than 28 weeks. Second step at the delivery room is after the baby is born is the temperature management. We have clamp and cut the cord at 60 seconds. So the child is moved to the warmer. Here is one updated rule, that is, do not dry the body of a baby which is less than 32 week. Important point is do not dry the baby which is less than 32 weeks. So preterm babies should not be dried. We must place this baby inside a plastic bag or thermal suit up to the neck immediately. So we wrap the baby in plastic bag but up till the neck. Why we are not drying the baby here is because drying removes the vernix and amniotic fluid but exposes the immature thin skin to massive evaporate heat loss, which can lead to hypothermia in baby. But there is an exception. You do dry the head and put on a hat because the head is a massive radiator for heat loss. So, we should not dry the baby body, but we dry the head part and then put hat on it to avoid massive radiation and heat loss. Here is one important update related to NRP 9th edition. 9 edition emphasizes that when we place the baby in plastic bag, there is a risk for hyperthermia, that is overheating. You must use a servo controlled temperature probe as soon as possible to maintain a target auxiliary temperature of 36.5 degrees Celsius to 37.5 degrees Celsius. So NRP 9th edition emphasizes on servo controlled auxiliary temperature of 36.5 degrees Celsius to 37.5 degrees Celsius. After the cord management and the room temperature management, baby's body temperature management, we step forward for the respiratory support and the oxygen point. So third one is respiratory support. First one is cord management, second one is the temperature management, and the third one is the respiratory support. This is the most significant update for our practice. Old school thought was we can start everyone at 100% oxygen. Then we sunk to room air 21%. But the 2025 guidelines says we should start at a specific FiO2 level so that we can avoid both the hypoxia, that is which can lead to death, and hyperoxia, which can lead to retinopathy of prematurity or BPD. So here we should not start everyone with 100% oxygen. So here is the updated algorithm of 2025 about fractionated oxygen. What we have, first one is 28 weaker, less than 28 weaker. Here we should start at 30% of FiO2 and we titrate it as per the level of oxygen saturation measured by pulse oximetry. So less than 28 week we should start at 30% FiO2 and titrate as per the SpO2 levels at 2 minutes, 3 minutes, 4 minutes, 5 minutes and 10 minutes. I will discuss it further in next part. So first one is 28 weeker, second one is for 28 till 31 week of gestation. Here the guideline says start at 21% to 30% depending on the need. And for babies 32 and above this, we should start at 21%. So respiratory support for less than 28 weeker, we should start at 30%. For infants less in between 28 to 31 week, we should start at 21% to 30% depending on the nature of need. And for infants greater than 32 week or at 32 week, we should start at 21%. And we should titrate for the SpO2 at 2-minute target, which is in between 65% to 70%. Why we are starting here at 2 minutes? Because we have clamped the cord at 1 minute. So 1 minute is for cord clamping. After that, we should follow this guideline. This is an update in NRP 9th edition. So at 2 minutes, the SpO2 target should be 65% to 70%. At 3 minutes, it should be in between 70% to 75%. So we should titrate this FiO2 levels as per the need of the baby so that we do not give extra oxygen or we do not give less oxygen so that we can prevent both hypoxia and hyperoxia. Both can lead to mortality. At 5 minutes, it should be in between 80% to 85%, and at 10 minutes, it should be in between 85% to 95%. So, if the baby is breathing, we should start the CPAP. So, for ventilation, we should start CPAP at 5 to 6 centimeter of water. But if the baby is apneic or heart rate is less than 100, we should start giving inflation breaths, that is positive pressure ventilation. So, if the baby is breathing, we start first at CPAP of 5 to 6 centimeter of water pressure. But if the baby is apneic or heart rate less than 100, we start positive pressure ventilation with a pressure of 20 to 25 centimeter of water. Here are few more updates. As per the ninth edition of NRP, we usually use pulse oximetry to measure this peripheral oxygen pressure, but NRP ninth edition suggests or emphasize use of cardiac monitor for this. For infant less than 28 weeks, which requires positive pressure ventilation, a 3 lead cardiac monitor is usually recommended. Pulse oximetry is now often too low. For an infant less than 28 weeks, which require positive pressure ventilation, a 3 lead cardiac monitor ECG is required immediately and is recommended strongly by ninth edition of NRP, because pulse oximetry is often too slow to pick up a signal in these first minutes. So, cardiac monitor is essential as per NRP ninth edition. Second one is emphasis on suctioning point. Do not suction routinely, even if meconium is present. Suction only if you suspect an airway obstruction or if positive pressure ventilation is ineffective. We also must avoid vagal stimulation as so. There is a strongly recommendation that we should not suction every baby. We only use suction if you suspect that the airway is blocked or we are doing positive pressure ventilation but it is still ineffective. So, suction only if the airway is blocked or you suspect that the positive pressure ventilation is ineffective. Third one is for intubation. If a child requires to be intubated, Nelson and Gomella emphasizes using a carbon dioxide detector to confirm placement, and this is non-negotiable. So, for intubation, carbon dioxide detector should be used to confirm placement. Now come to the last phase of this, that is the stabilization phase or the NICU phase. Now the airway is secure, the baby is pinking up, and we move the baby to the NICU for metabolic stabilization. This is crucial. Now, for the baby to be stabilized as per their metabolic need, we must have an axis, that is the vascular axis. In preterms, we usually use umbilical venous catheter for the axis because this is the lifeline of the preterm infant. So, do not waste time with peripheral lines. Place a 3.5 FR UVC immediately. So, we usually place 3.5 FR. Ideal is T8 and T9, that is above the diaphragm. So, the tip of the UVC line should be at T8, T9, that is above the diaphragm. Tip position should be at T8 or T9. But if the UVC cannot be placed rapidly in a bradycardic infant, we should pass the IO line. So if the UVC is not placed, shift to IO line as emphasized by NRP 9th edition. This is also a rapid alternative for fluid and epinephrine. Now, the vascular access has obtained. Now, after this, we should start the fluid and glucose because preterm babies have almost no glycogen reserves and they are at risk of hypoglycemia. And we all know that hypoglycemia is a brain injury risk. So, we should start fluid, that is 10% dextrose immediately. So, first we have to establish the vascular access and then we should start the management plan of fluid and glucose. So, starting 10% dextrose is required. The 2025 guidelines recommend starting at 90 ml per kg per day for babies less than 1 kg and 60 ml per kg per day for those which are greater than 1 kg to account for high insensible water losses. So, for less than 1 kg baby, it is 90 ml per kg per day. And for greater than 1 kg baby, it is 60 ml per kg per day. After the dextrose, we should also start the total parental nutrition immediately within 0 to 2 hours, because the preterm infant is at risk of catabolism. So do not wait for pharmacy. Start a standardized TPN solution containing amino acid. Because if you only give dextrose, these babies break down their own proteins within a minute. We must prevent catabolism instantly. Start TPN immediately. After the fluid and glucose, we must protect the preterm from the infection and we must protect their brain. So, infection and the neuroprotection is required for all the preterm. So, for antibiotics in this neonate, benzyl penicillin and gentamicin within the first hour after drawing blood cultures should be started, because early onset sepsis can mimic RDS. And to protect the preterm from intraventricular hemorrhage, that is the neuroprotection of these babies, we must place or keep the head in midline. Second most important point to avoid intraventricular hemorrhage in these babies is to avoid rapid boluses. This rapid boluses can change the blood pressure or the brain vessels pressure drastically and can result in intraventricular hemorrhages. So avoid rapid boluses. And the third and the most important is to minimize handling of these babies as much as possible so that we can avoid the infection as well. Minimize handling. So now the lecture is almost complete. We have done the before delivery phase, at delivery phase, and the third phase, that is the stabilization phase. So to summarize this lecture, that is the ultimate guide to the golden hour, we have some major points. That is, we must prepare the room, and the room temperature should be 25 degrees centigrade. Second one, we must delay the cord clamping for at least 1 minute, and there should be no cord milking, as there is increased risk of IVH while we milk, because of the vessels are very fragile. And the third one is airway. If the baby is breathing, we start the CPAP at 30% and then titrate to NRP targets depending on the age of the preterm. If the age of the preterm is less than 28 weeks, we start at 30% of FiO2. If it is in between 28 to 31 week, we start at 21% to 31%, and at greater than or equal to 32 week of gestation, we start at 21% and then titrate. Next one is the access. We usually access through the UVC. If it is not possible, then we go to the IOCHA lining, and the last one is to protect the neonate. So we start antibiotics, place head in midline, and minimal handling. If you master this, you can reduce the mortality and protect the baby. Inshallah, in our next lecture, we will discuss another topic related to neonate. So, if you like this lecture and if you have any query related to this lecture, you can comment your query as well. I will try to answer all your queries. This video is prepared from different resources. Few of them is Neonatal Guideline, Nelson Textbook 22nd edition, Current Pediatric Diagnosis and Treatment Book 27th edition, the Bible of Neonatology, that is Gomella 8th edition, and the last but not the least, NRP 9th edition. This lecture is prepared after using all these books, but if you find any mistakes, you can comment that as well in the comment box. I will try to update my lecture in the next video. This lecture is purely for educational purpose. This is not intended for any medical advice or counseling or consultation. Consult your doctor if you are watching this video before taking any decision. Till the next video.